So for women over 38, what fertility testing do you usually recommend first? I know you kind of already talked about this, but
Yeah.
yeah, you can
No,
go
I
a
just
little
talked in general, but I
right.
think that at 38, because we're talking about 38-year-old and the subject is 38, but the reality of the matter is all the tests are all about the same. Let's
Mhm.
put it this way. When a patient comes and wants to analyze if they're fertile, not fertile, how fertile they are, to either freeze eggs or get pregnant or freeze embryos or see if they need egg donation or surrogacy, pretty much what they need is a consult to determine if there's medical issues or any conditions that would have to alert us to go one way or the other. Once that's done, usually we ask the patients to call with their period on day one, then to be seen within the first 3 days of their cycle, because that's the perfect time for us to do a hormone test called estrogen and follicle stimulating hormone test. Because at that point, if the follicle stimulating hormone FSH test is less than 10, that is instructive, that it helps us. But if you do it, because I get patients coming in and they have an FSH, but they didn't do it the right time, and it's like 12. And I'm like, well, when did you do it? Like, mid-cycle. I'm like, no, 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 that's the wrong time. It could be 30 at that point. So you have to do it within that time period. Uh, some people do a blood test called inhibin B, some people don't. That should be done that time. We also count the follicles at the date of called antral follicle count. And we count the follicles to see how many we have. We should see about 15 on both ovaries total. We do a blood test called anti-Müllerian hormone or AMH, but that blood test can be done anytime. But it doesn't have to be with your period, but you're getting blood drawn, might as well get it all done. The AMH test tells us about egg count or ovarian reserve. The FSH tells us about how hard the brain works to get an egg out. And the follicle count tries to corroborate the AMH and the follicle count to make sure that the numbers match. And is there a problem? Because if you have 15, the AMH should be 1.5. If you have 20, the AMH should be 2. And if you have 3, the AMH should be zero point 0.3. So you get the trend. Also, other tests have to be done like thyroid, vitamin D, STD, carrier screening to make sure there's no genetic abnormalities that could be overlap between the two. And blood types and so forth. On day 7 to 10 of the cycle, we need to evaluate the uterine cavity to make sure the cavity is normal, uterus, and the fallopian tubes for patients who are trying to get pregnant on their own or with less aggressive treatment. But if we're doing in vitro, we just do a water test of the uterus. The partner, if the partner happens to be male, will then get a sperm analysis, STD panel, and genes testing. And so once we have all this data, a few weeks later, we sit down and review all this information to see, based on their age, their history, and their x-ray, and their sperm, and their blood tests, is there a problem? Is there something to address? Or should we just look into how we can improve their odds?
Gotcha. Yeah, thank you for going like step by step through that. All right, let's go to question 5. So many intended parents focus heavily on AMH numbers. I was going to say that's probably a number one question we get asked with when it comes to like donors. So how accurately does AMH actually predict fertility or IVF success?
Yeah, I think that you don't want it to be low. But even low AMHs, people get pregnant. It's
Mhm.
just a number of eggs. So, for example, if someone's AMH is 0.3 and normal is 1.5, that means if you count the eggs, you'll see 3 follicles per month released, and you only need one to get pregnant. So, I mean, we are alarmed because it's lower, but not so alarmed that you cannot get pregnant. On the other end, if it's 1.5, we're ecstatic. And we're not too happy when it's a 5 because you see the number is just one factor. That AMH correlates with your follicle count and ovarian reserve. But it can also be problematic when it's too high because that could be a polycystic ovarian syndrome, PCOS patient that has that. So in those patients, they may have a high AMH, but then there are a lot of eggs, but they're not a lot of good ones. So you got to look at it that. Now, you were saying that some patients looking for an egg donor are fixated on the AMH, and I get it because they want more eggs so they can have more embryos so they can get pregnant. But I think it's reasonable to say that someone's AMH hovering on 1.5 to 2 is a reasonable number for an egg donor. And for someone who comes sees me at 38 or 40, a lot of times their AMH is not going to be that. It's going to be 0.9, 0.7. But that doesn't mean that anything wrong. It just means that we have less eggs to work with, but we can get them pregnant still, God willing. I mean, the point is obviously everybody's heard of a story of someone with 20 eggs that ended up with one blastocyst, and someone with three embryos ended up three eggs ended up with two embryos. So I think that there is a lot more than just an AMH value. There's, as I just said, the whole picture. But I guess if you had to put your finger on, hey, I'm going to look for someone with an AMH of 0.5, 1.5 or higher, that's great as an egg
Right.
donor. I
Mhm.
wouldn't certainly pick a donor with an AMH of 0.5 because that's not going to work for us.
Right. Yeah, I think especially when looking for an egg donor, you want to check like the AMH and what you've reviewed.
Yeah, I
Oh,
think the story is important. The history of the person, have they had kids, and have
right.
they done cycles before, and what was the results, and how many got fertilized, how many embryos were created, how many were normal, did they get pregnant? That's a lot. That's huge because that means that not just a blood test, but a history in an egg donor situation. I hope that makes sense what I said. Can you still hear me? Or are we frozen?
Oh, hello. Sorry, it looks like you cut out for a second, Dr. Nash.
Yeah, I think we got frozen for some reason. I have full bars. I don't know why. So I was just saying, basically, it depends on the entire picture, not just one number.
Right. Okay. Thank you for that. So for question 6, when treating patients over 38 or 40, what are some of the biggest factors that influence IVF success rates?
So you're talking about a patient trying to get pregnant and they're doing in vitro and they're 38, 40. Okay.
Correct.
So that's most important informations are from the first visit, by the way.
Mhm.
So you have a partner who says that they have gotten someone pregnant before, let's say, or the patient has already gotten pregnant and had babies before, or the patient with another partner has had pregnancies before. Because you've got a proven fertility, it gives you a check mark.
Right.
There's a higher chance. But some people have not tried, so that doesn't mean it's negative. It's just we don't know. So I think a history of fertility is important. And how long it took to them to get pregnant is important. Was it like they have two kids, but for each one it took 3 years versus 2 months? So those pieces of information are important. History of STDs or sexually transmitted diseases that can cause damage to the fallopian tubes, scarring is important. History that could suggest endometriosis in a female patient, which could cause them to have inflammation, scarring, or implantation issues is important. So I think what I'm trying to say is that it's important for your doctor to talk to you, ask you questions, get the facts, and you give them all those facts because it's helpful to kind of figure out where you're at. And then the next question is, okay, for example, prior history of miscarriages and DNCs can lead you to thinking of egg quality issues or maybe uterine scarring or autoimmune or clotting problems. So once you got all those factors figured out, then the important thing becomes, okay, what is your egg count, egg quality, AMH, FSH, and the big picture. So the history, then the facts, and then together you can become more, it would be more of a better guesstimate of what the odds are. Does that answer the question?
Yeah, actually, I have, I guess, a personal question to add to that. Do you typically like go into detail with patients about maybe their family history, like their like mother, father's
Yeah,
history?
so we ask that in our questionnaires,
Mhm.
and then if it triggers any answers, then we start digging into it. So I don't really go into grandpa or grandma stuff, but I basically, if there's a history of this, that, and we're like autoimmune disease, or there's early menopause or multiple miscarriages, things like that, then it kind of triggers us to go into that. Because, for example, thyroid issues, a family happens more often in families. So then we're like, okay, what is this situation? Do we need to address it? Is there an autoimmune condition going on? Or like today, I had a patient who says, "Oh, I had a family member who had DVT, and then the other one had a pulmonary embolism, and someone had a heart attack. And I'm like, whoa. And she's having miscarriages. So I'm looking at autoimmune and clotting problems, right? So those history is important because it's not a cookie cutter situation. You have to kind of address it. That's why, like, for example, in our clinic, you know, we're not a factory. It's like a more of a concierge situation where we spend time and sit down and talk and figure it out. Yes. So I think the information is very important.
Awesome. Yeah, let's move on to question 7. So I think you've also touched on this lately, but a lot of patients believe that, having more eggs automatically means better chances. Is the egg quantity or egg quality more important overall?
Oh, is this a trick question? I'm just kidding. So obviously quality is more important than quantity. Having both is great, but if I had to pick one, I would say quality. So the point being that I just had a very interesting situation. So I'll give you an example. I had a gentleman in another continent give sperm, purchased eggs from 2 twin sisters, like they had in an egg bank, twin sisters. One twin sister had 6 eggs, so he purchased that, but he needed more, so he purchased another 11 from the other twin sister. So now I have 11 and 6. We injected the sperm into the 6 eggs, the 5 eggs that survived, and we ended up with 4 gorgeous embryos from that 6. On the 11, same sperm, apparently same gene pool, it only ended up with 2 embryos. So I know that it's not the sperm, it's not the lab, it's obviously potentially something in the lifestyle of this second twin sister. So quality over quantity. And so I think that that's what's important. Quantity is a nice, but quality more important.
Yeah, I feel like for most things in life, you could say quality is probably better. But yeah, it's cool that you had that experience where you had the twins and you're able to.
Right. I mean, because how often does that happen in your life,
Yeah.
right? Yeah.
All right. So for question 8, another topic many patients ask about, especially at like the advanced maternal age, is embryo testing. So we can talk about the PGT-A testing. So how does embryo genetic testing help patients of advanced maternal age? And are there situations where it may not be necessary?
Well, that's like a 1 hour discussion, but let me shorten it because I mean, there's so much in here. Okay,
Right.
bottom line is PGT-A is for testing for aneuploidy, which basically means to make sure that there is a 46XX or a 46XY embryo, and a Downs embryo would have an extra chromosome 21. And like, for example, a monosomy 16 would be missing a chromosome 16. And that's what a PGT-A test can tell, in addition to sex. PGT-M is specific for gene disorders, like a cystic fibrosis or something. So we're talking about PGT-A. And PGT-A has been around for many years. And at first, it was like this unbelievable tests that cannot be, why would you not do it? But reality is, to biopsy an embryo, there's a 3 to 5% chance of damaging it. When you test the embryo and you take a sample out and then you freeze the embryo, the accuracy of that test is 90 to 97%. That means there's a 3 to 10% error. Depending on which lab it's sent to, you can get different results. And at the end of the day, the results are sometimes not accurate because I've had patients that have had monosomy embryos from another clinic, which I basically said, with proper consent, if you're willing, we are willing to put this embryo in. Why spend more money? And the patient had a normal baby. Of course, we test them at 10 weeks. So there is this potential that the embryo result as an abnormal and it's actually normal. Now, I'm not talking about complex extremely abnormal with multiple abnormalities. I'm talking about one little abnormality. So the point being that there is potential for damage, there is a potential inaccuracy, but 90-97% is pretty good, but still error. Now, the next question becomes is, does it improve outcomes? And the answer is debatable, but certainly in a patient with recurrent pregnancy loss with aneuploidy detected or abnormality detected on the products of conception, it could help at least identify a normal embryo. In a patient with advanced maternal age where they have higher risk of abnormalities, it would determine the normal ones. In patients who've had multiple IVF failures, it can be helpful if they didn't have genetic testing. But I don't think it's really clear that it helps patients below the age of 35. I think it's understood that above the age of 35, there is some benefit there, definitely above 37. By 43, you should be testing because 75% of your embryos are abnormal potentially. So I think you have to use it this way. Now, there are cases where you actually look at it and say, you know what? There's only one embryo here. If we put it in and it's abnormal, it may not take, it may take, but if it gets to be 10 weeks, we will know. We can abort if we need to, as long as you are accepting of that. Do we really need to biopsy it and go through freezing and thawing and testing? And so it becomes a debate if we should do it. Just because it's available, do we need to do it? And I think it's not specific to like a doctor's opinion. It's a balance between the explanation of the doctor and what the patient's accepting of. One person is not accepting of any error and wants the highest level of testing. Well, then that one embryo gets tested. Another person might be a little bit more understanding and allow nature to take its course, or not wanting to be invasive, so that person will not do the testing. But I think it's a balance between what the doctor's explanations are and the patient's desires are and what they're accepting of. I hope that makes sense what I'm saying.
Yeah, that definitely, I like to know the nuances of that discussion. So that really opened my eyes up too to like, it just varies depending on the patient's situation.